Having talked about the technology model and studies that have directly evaluated its assumptions, it's now time to consider the implications. And we'll talk about the implications not only for clinical applications, but also for research. And I want to take you one step further and talk about the implications for designing or studying treatment systems themselves. So what are the implications of the technology model for treatment matching? What we learned, particularly from these outpatient studies, is that motivational and cognitive behavioral therapies may not be effective according to the assumptions of the model. That's not to say that they aren't effective, and it's not to say that they don't produce changes in whether in motivation or drink resistance skills. All it means is that if they're exposed to these treatments, they're going to do better in treatment, but not necessarily whether they learn the skills or they increase their motivation. So skills training does indeed produce better drink resistance skills, but the skills don't produce better outcomes. Motivational therapy improves motivation, but the motivational changes don't predict better outcomes. People who are motivated at the beginning do better after treatment, but not necessarily what goes on during treatment. And similarly, the 12 steps of Alcoholics Anonymous may not start, as we learned from Project Match, with a religious conversion or hitting bottom. But parts of the AA model were verified in that changing an individual's social environment and affiliating with people who are abstinent and who support a person in recovery, those are ingredients of AA that seem to be highly effective. What about mediators and moderators? Well, we didn't find strong evidence for mediators. We found some evidence for moderators, but the most important thing I think we learned from studies so far is that the decision to enter treatment is associated with considerable reductions in drinking behavior. And regardless of the type of treatment you get or you go into, you're going to come out better because you went into treatment, regardless of whether it's mindfulness, motivational enhancement, cognitive behavioral, or something plugging you into AA. Another implication is that the value of different types of treatment may be to convince the clients that treatment is going to help them. So it brings people hope. It helps to marshal their resources, and it gives them a rationale, a strategy to decide to bite the bullet and go into treatment. And that may be the real value of many of these treatments. So what we're learning is that a key ingredient of the success of any therapy may be its ability to attract clients. And one way this is done is by generating enthusiasm among therapists. So therapists are quite effective in getting people into treatment and convincing them that the treatment is going to work. And if they can do that, then people will get better regardless of the type of treatment they get into. That means that access to treatment may be as important as the type of treatment. And keep that in mind, because what we've been studying for the most part is what goes on in treatment. And what this suggests is that maybe we should be devoting equal attention to studying what gets people into treatment in the first place. Because the more people we can get into treatment, the more people are going to recover. Another implication is that the technology model of psychotherapy in particular may be flawed. Instead of distinct, non-overlapping elements, therapy may work through common mechanisms. And some of those mechanisms are likely to be empathy, competence, an effective therapist-client alliance or connection, a desire on the part of the patient to change, an important moderator, the inner resources that patients bring to treatment, a supportive social network that occurs in the post-treatment environment, and the provision of a culturally appropriate solution to a socially defined problem. What do we mean by that? Well, treatment, as we saw at the beginning of this course, can be delivered quite differently in places like Russia, or in some countries in Africa, or in Latin America, or in Asia. And those types of treatment may seem to be quite different to people in the United States, but in fact, they are culturally appropriate. And from what we have learned from the psychotherapy process research, if the therapeutic process is effective because of these generic common mechanisms, then many treatments in different countries may have enough of these common elements to be effective, rather than the specific types of treatment that are delivered. We may learn from this research that other types of mediators are worth studying for their matching effects and for the mechanisms that we're trying to understand for mediation. Different treatment settings, for example, whether it's outpatient or residential or primary care, could serve to mediate different effects. And primary care in particular may be very helpful in convincing people to try abstinence when they become dependent, when they wouldn't have gone into treatment at all because of the stigma involved in going into a residential program or a program that's defined as being for people who have substance use disorders. So treatment in primary care, for example, could be an important area to study for the reason that it could serve, the setting itself could serve as a mediator of a treatment effect. We also could learn a lot from studying family treatment programs and group treatment programs. Thus far, we've been talking about most of the research being concentrated on very specific types of individual therapy, in part because it's easier to control for extraneous variables. But group therapy certainly is a staple in the substance abuse world. We know it's effective, and the question would be, is group therapy better than individual therapy? Does it work for some types of patients? That's another thing we can learn by further research. And finally, it'd be interesting to know whether if patients had a menu of options for treatment, would they self-select into treatments that fit their particular needs? And some of those needs may be psychological or social. Some of those needs might be very practical, like going to treatment when you have a 9-to-5 job, or going into treatment that suits the unique situation that is faced by women who are alcohol or drug dependent during their pregnancy. So programs that suit the specific needs of individuals may be more effective, and patients may self-select into those treatments and do better. At the level of treatment systems, I'd like for you to consider how you can apply some of these concepts to the level of the entire system. Could we be looking for mediators and moderators and matching in larger populations at the level of communities or treatment systems themselves, where a wider range of settings and therapeutic interventions can be evaluated? We could, for example, study how formal treatments and mutual help societies alter the long-term drinking career of individuals, large numbers of individuals. So how many people are getting into different treatment settings? Are they or more people getting into treatment because the treatments are more attractive, or they're being marketed better? Or they're being designed to suit the unique needs of patients, or there has been a reduction in cost based on insurance coverage. There are many things that could be studied at the system level that could be considered to be mediators and moderators of change. And we should therefore be considering how the structural features of the system itself, the number of facilities, the number of people working as therapists, how the system is integrated in terms of its system qualities, and whether it is equitable to people with different socioeconomic backgrounds. If we could take all of those system characteristics, we might find that the more that those facilities, structural features, and system qualities are optimized, the better that the system does in reducing population rates of alcohol and drug problems. So I'm going to leave you with those thoughts and encourage you to think not only how we deal with the understanding of what goes on with the black box of treatment within a particular treatment episode for individual patients, but what goes on in the black box of the treatment system itself.